Uh, Thank you for the opportunity to present here this afternoon. We've really got the great pleasure of having an exceptional guest speaker, Jamie Craig. Jamie is Professor of Ophthalmology and Director of the Flinders Centre for Ophthalmology, Eye and Vision Research. He's also Chair and Academic Head of the Department of Ophthalmology at Flinders University. He's a practicing consultant ophthalmologist and is an NHMRC Senior Practitioner Fellow. Today, he'll be talking to us about some of the latest advancements in his research program in the area of glaucoma investigation. And I would be grateful for, if you could, thanks for joining this seminar series.
Great. All right. Thank you very much, Anand, and thank you for joining in the seminar. I'm going to be talking about some of the most recent results that we've got in risk profiling for glaucoma. And this is a talk about the way that we've developed a polygenic risk score strategy for glaucoma and how we think that can be implemented into clinical practice to reduce blindness from glaucoma. So glaucoma is a disease that is painless and slowly progressive. So in the early stages, patients don't often present with symptoms and they gradually lose peripheral vision and until that becomes an extreme level when they may bump into things and notice that the quality of vision has gone down. And without treatment, it does end in total blindness, so no vision at all, which often happens in the developing world. Fortunately here, we tend to diagnose earlier and we're able to implement treatments, which are things like topical therapies, eye drops, laser and surgery, which are very good at slowing disease progression and preventing blindness. So one of the interesting things about glaucoma is it's one of the most heritable diseases in medicine. So for a common disease, it's certainly in the top 2 or 3 for heritability scores. And so a complex sort of genetic etiology, which involves both rare and common variants, but I'll be talking mainly about common genetic variants or SNPs. We know that if you have a self-reported family history of glaucoma, it does increase risk, but it's a very blunt tool because people are often not very aware or don't have a very accurate family history. We know that if we diagnose patients early, it's a key to preventing blindness. So for the context, at about retirement age, about 3% of our population have glaucoma, and that rises to 10% at age 90. So this is going to be a much bigger problem as the population ages, and about half of patients who are walking around in our population have early stages of glaucoma that are not yet diagnosed. So there is an opportunity for better screening, which currently is not cost effective on a whole population basis. About 10% of patients in our population develop very severe levels of vision loss, either because they present late or the disease progresses whilst on treatment, contrast to the developing world where almost all cases end with very severe disease because treatment's not well available. The biggest risk factor for glaucoma is raised intraocular pressure, which is like a plumbing problem at the front of the eye, developing with age. But there's also a component of what we call normal tension glaucoma, which is a neurodegenerative process of the optic nerve and death of retinal ganglion cells for potentially non-intraocular pressure related causes. That's called normal tension glaucoma. And for the work that we've done, we've relied a lot on what we call endophenotypes. So we've gone into population databases which have intraocular pressure measured in large numbers of patients like the UK Biobank, and optic disc photos where we can measure the cup to disc ratio, which is one of the markers of degeneration over time. So that increases our effective sample size to discover genes for glaucoma. So if we went back 20 years, we probably knew of like 1 gene for glaucoma, and now we're up into the hundreds of genes in the last couple of years. So the timeline of the disease is that there are detectable changes in the retinal nerve fiber layer early in the disease process before vision is lost. But if you focus too much effort on finding people very early, you end up with very large numbers of people called glaucoma suspects, where you're not sure if they're going to progress to full-blown manifest disease with vision loss. So we need better ways at picking which patients are at high risk. So that's been a big focus of my research and the registry project that I started called the Australian New Zealand Registry of Advanced Glaucoma. And in this project, we have recruited patients who have lost a large amount of vision, what we call advanced glaucoma. That may be because they've presented at diagnosis like this patient, or it may be because they were lost to follow-up or they didn't respond to treatment. But we set about from starting from scratch to have as many of these patients with DNA as we could, and we now have several thousand of those, which I'll come to. We also run a longitudinal study, which is Australia-wide, but most of the patients are here in South Australia. We have 2,050 patients enrolled now, and we're looking at the risk factors for disease progression. So you start out at a stage where we're not sure if they're going to get glaucoma, and this patient, as an example, has converted to some early vision loss on the bottom left there with field loss, and we measure that also structurally with the retinal nerve fiber layer. Other patients won't progress and just remain what we might call a glaucoma suspect. So this is our website for the advanced glaucoma study, and this is where we're up to now. We have 3,000 patients with meeting advanced disease criteria and many less advanced suspects and family members now that we also recruit and work with, and we have extensive international collaboration on this as well. But this has enabled us to build a lot of genetic power to do gene discovery in our cohort. So I mentioned that only about 10% of patients in our population end up with severe levels of disease. There's far more with mild disease and in these suspect stages where we're not sure whether to start treatment or not. And that's a big part of my translational focus, is identifying which ones of those ought to be treated early so that they don't move into the advanced stages. So the genetic architecture, the earliest discoveries were with Mendelian or large effect size genes such as mycilin, which were found through conventional linkage and family studies. And then the more recent work has been on genome-wide association studies, which have found the common variants that are, you know, of reasonably significant effect size as well, but cumulatively add up to very important risk factors. The problem with the rare variant work is that even in our advanced glaucoma registry, only around sort of 4 to 5% of patients would have a rare variant causative of disease. So by far the majority, we had no idea what caused their disease until we started having success with the genome-wide association study approach. So our first success really was on about 700 advanced glaucoma patients, which we had at the time, and had a grant to run a GWAS. And we found 2 genes that met genome-wide significant association levels. They're listed here, and I won't go into a lot of detail about those, but the odds ratio for each one is about 1.5, which is quite big for a common variant, but individually not enough to really alter clinical practice. Often we don't know the function of these genes, but one of them causes raised pressure and the other one causes neurodegeneration. But as we increase the sample sizes, we were able to generally find another 2 or 3 loci each time you doubled the sample size. So working now in a sort of international consortium approach, we've been able to increase that to 127 genome-wide significant loci for glaucoma. And then we start incorporating what we call the endophenotype work on intraocular pressure and vertical cup to disc ratio. That's enabled us to build a risk profile that actually is several thousand genes, so around 2,600 genes, which were combined with a multi-trait approach. And we work here with Stuart McGregor at the QIMR, which is where I am right now at a conference in Brisbane. And this was, I guess, a very quite innovative approach to build a more powerful polygenic risk score when we didn't have additional samples of case control that we could go to. So to do that, we used the UK Biobank, where we had intraocular pressure measurements and optic disc photos, which we graded, and we were able to combine all those results together to come up ultimately with a polygenic risk score that has around 2,600 genes. So for those who are not too familiar with this sort of approach, what we do is we identify the SNPs individually, look at their odds ratio, and then we will combine them together into a single polygenic risk score that is weighted for the effect size of the gene. So the early discoveries are weighted stronger because they have a higher odds ratio. And then we look at the distribution in the population. And, we might work with, say, the top decile or the bottom decile. So that's what we've done. And what I'm going to present now is, I suppose, what are the clinical implications of the polygenic risk score that we've identified and developed. And, we were very sort of pleased to find that the odds ratio for glaucoma prediction using this polygenic risk score was massively better than anything that we'd ever seen on the smaller studies. So if we compared the top and the bottom decile of risk in the population, it will shift an individual's risk by about 15-fold, and we can get fairly respectable area under the curve for even population level screening. Obviously, that's an age-dependent thing. You really need to be in an age group where glaucoma is starting to become prevalent. We found that our risk score was much more effective in high tension glaucoma than low tension glaucoma, although it does work in both. So some of the variants work through high pressure and some through neurodegeneration. And in comparison to other sort of leading diseases in this field, our effect sizes are greater with our polygenic risk score currently, and that is sort of improving over time. So when we look at, I guess, what are the clinical implications? One would be that we would hope that we might move to a level where we could screen people at, say, age 50, find those at high risk, and then they would be directed into a screening program. But there's a lot of health economics to be done before that actually sort of becomes a reality. And we obviously need an accredited test, which is what I'm going to talk about now. The aim of doing that sort of screening piece would be to find people who are at high risk and get to them when they've got early disease, not presenting with late disease. But if we look at the clinical markers in our registry and progression study of patients who do have a high polygenic risk score, we were really pleased to find some strong associations. So age of diagnosis was about 10 years younger in high-risk individuals. So that has important implications for screening. We were very surprised to find a very strong correlation with the number of relatives that a patient was known to have who have disease. So if you as an individual have a high polygenic risk score, it tells us something about the likelihood of your siblings, parents and children also being affected. So that's an important translational piece. And in the early glaucoma study where we look at disease progression, we've found some quite interesting results. So high polygenic risk individuals show faster rates of progression and conversion. In both of our studies, we find a strong association with the amount of treatment that clinicians have done. So patients requiring surgery, which is high risk, have much higher polygenic risk scores, and the amount of treatments that are put on low risk patients is also strongly correlated with the polygenic risk score. So just recently, we've looked at visual field progression, and Ayub Quazim presented this work at the conference that I'm at now. Visual field progression is quite a tough thing to measure change over time because there's a bit of variability. So this particular work took into account 27,000 fields in the longitudinal study from around 1,300 patients, and it showed that there is a much higher rate of visual field worsening than in patients who are in the high polygenic risk group. So this sort of ties it back to the likelihood of disease progression, and that's despite patients in high risk groups being treated more. So clinicians who are at liberty to treat those patients, because it's not a randomized intervention study, it's an observational study, we found that high risk patients are being treated more, but they still progress more. That means that their risk of progression would have been much greater had they not been treated. And to show that just in another way, in a very recent bit of work we've done, if we look at the likelihood of patients' treatment was initiated from scratch or escalated if they're on treatment, we can see a very clear separation in the three groups here with the top and bottom decile and the intermediate groups. So what we think that tells us is that if clinicians knew that result early with an early patient, it would influence their decision of when to start treatment, when to escalate treatment, and when more risky surgery should be leveraged on the patient. So to make that point in a single case, this would be a patient starting the study with very early or mild disease with no vision loss. By the time we'd escalated through all the treatments and arrived at surgery, she had lost about half of her visual field in both eyes and is now stabilized. And her polygenic risk score was on the 96th percentile. Obviously, we didn't know that at the time because we've only really had these scores for a couple of years and it's not yet accredited to feedback. So the steps to improve this are to increase sample sizes. We're looking at incorporating patients from the other ethnicities so that it's not just restricted to Caucasian patients. And obviously there's a bunch of steps that need to be gone through for accreditation. So we're working with, clinical geneticists doing the reporting strategies, the education strategies, getting the NADA accreditation in place, working out the multi-ethnic and mixed ethnicity issues that have to be dealt with. And we've designed a number of clinical trials to look at implementation of this, and including early intervention with laser in patients who have not yet lost vision. So there's a whole range of work that's going on in that space. And using sort of AI approaches, we're also putting together all the clinical risk factors of early patients with their genetic risk score, which enables a much greater separation of the risk of disease progression over time. And that's data there at 3 years, incorporating clinical and genetic risk concurrently. So in summary, what we hope to be able to do is deliver a precision or personalized approach to diagnosing, monitoring and treating glaucoma, where we'll be able to save money by less intensive monitoring and specialist involvement in low-risk cases, but enable high-risk cases to reach specialist care early, to be treated earlier in the disease process and to avoid loss of vision. And in doing that, we're commercializing this polygenic risk score and accrediting it with an Australian startup company to try to deliver this into clinical practice during next year. So with that, I'll just thank the very many people who have contributed to the case recruitment, and in particular, Ayub Quazim is a PhD student whose data I showed there on visual field progression, and Henry Marshall, who is working with Owen Siggs on the treatment escalation strategy. So I'll leave it there, and thanks very much for your attention. And just to acknowledge also the funding sources from the NHMRC and great support from Glaucoma Australia, who's our patient support body. Thank you very much.
Thank you, Jamie. Thanks for a wonderful presentation. I don't see any questions from the audience coming up, so I might kick things off. When do you see this coming into clinical practice, and what do you think it will cost? Yeah,
so I think we have a sort of a pipeline where we've taken the research pipeline from the QIMR, replicated it, and doing the validation to show we can get the same results as we have on the research program, and that's well underway with an application which will soon be lodged with NADA. So that means that it'll need to be assessed.
Are you able to tell us what NADA is? I don't know.
Oh, sorry. That is like a testing authority for pathology tests. So laboratories who deliver a test that is going to be fed back to affect patient management have to meet accreditation standards. And that certainly includes all genetic testing. And because this is a new area, polygenic risk scoring, there isn't really a strong rule book on what is required to accredit a test. So that is a process that will take perhaps an unknown amount of time. So we're sort of hopeful in the first half of next year. And we'll certainly have a test that can be delivered on a test basis for clinicians who might be interested in trialing it in the next 3 months. Cost, when you take into account the DNA collection, that it has to be at an accredited standard, running the array is an Illumina array. It's currently an off-the-shelf array. If you add up those sort of costs, it's going to be approximately $300. That could come down reasonably rapidly if there's scale, because small batches cost more than large batches. But you're probably talking about a $250 to $300 cost base to deliver What patient populations do you see this being applied in to start with? No, that's a great question. I mean, we, as ophthalmologists, we see a real opportunity in early stage disease where we're not sure how aggressively to escalate treatment, so that when we have those results that say this patient's at very high risk, we would probably be intervening earlier and more aggressively. In optometry, which is primary care settings, they refer those patients on for assessment to ophthalmology. and often there's long waits in the public system, some years sometimes to be seen, and there's a waste of resources if a low-risk patient is referred on and then just sent back with no action. So we think that that will enable low-risk patients to stay in primary care and high-risk patients to be referred early. So that will be a piece in what you might call collaborative care. And family members of established glaucoma patients are always counselled about their increased risk, and we try to inform them that they should go and be tested. But they often are unsure of how much that applies to them, what is their level of risk, and how often they should be seen. I mean, guidelines would suggest probably 2 yearly after the age of 40 if you have a family history. But often people get a bit sort of sick of going if they went 3 times and there was no abnormality. But if they're in a very high risk group, they obviously should continue to maintain that follow-up. And low risk family members may just be able to be managed as per the rest of the population. Ultimately, we would like to think there's a place for a population-based screening approach for glaucoma based on a generalized array results. So that might be done at age 50, or it might be done in kind of medical record in the future.
So, yeah, and another question I have is, this is derived in a predominantly Australian and UK primary source data. How well would that translate to other communities and people of different backgrounds? Yeah,
it's a very important question. Our population here is, if you look at our registry enrolments, it's approximately 90% British, Western European derived. And that has been what we've got for our replication and validation results. The discovery results from the UK Biobank, there is a substantial South Asian population. So we've already validated it in what you might call Indian background patients. We're well underway in doing that in East Asian patients like Chinese, Korean, Japanese. The current test definitely works, but we can't necessarily say it has those same clinical implications. African patients have a very high rate of glaucoma and predominantly high pressure. And we see that the test will work, but we haven't had the sample numbers yet to be completely locked down on that. So that is a thing that we're doing in collaboration now. And for mixed ethnicity patients, which is a common scenario, we have to, some different approaches to reporting. So it's a work in progress. It will be possible. It will work, but that will improve over time.
From the gene identification strategies that you've developed, do you see that there's possibilities of developing new treatments or therapies? Are there any things that are new molecular targets that are emerging out of this research?
Yeah, very definitely. I mean, I think we didn't have time to go into it, but in the rare variant work that we do, particularly in young onset glaucoma, we've found a number of genes in the last 2 to 3 years, a couple of them even unpublished, that work in pathways that were unexpected but strongly involved in intraocular pressure regulation. So the angiopoietin and TEC, which is the angiopoietin receptor pathway, is massively implicated. And yes, you can interfere in that pathway and change intraocular pressure. So that's one example. In neurodegeneration, there's some work that is based around the NAD and NADPH pathways and oxidative stress. And there's gene therapy trials underway that might be neuroprotective. And, there's probably 3 or 4 other examples of targets that have come up which might be druggable, or they may be able to be interfered with gene therapy. So Mark Hassel, who's in our group, has a PhD in gene therapy, and we've been working collaboratively with Bob Cassin's group at Adelaide Uni, and in a rat model have demonstrated protection with AAV vector-driven delivery for a neuroprotective target that we identified through our sequencing studies. So there definitely are opportunities, but they will take longer to reach the clinic than what I'm talking about, which is basically delivering the current standard of care earlier, and that's translatable within a year or 2.
Yep. Excellent. No worries. That's really amazing work, Jamie. I don't see any questions from the audience at this stage. So I think I'd like to, I hope the audience will join me in thanking Jamie for an amazing presentation this afternoon, and thank Adelaide Biomed City for the opportunity to listen to him presenting his research. Thanks again.
All right. Thank you very much for the invitation. I really appreciate it.